Good afternoon, everybody. Salam alaikum. Thank you very much for the invitation. And I would like to thank the organizing committee for inviting me to the 11th Saudi Society of Rheumatology Conference. Actually, I remember myself the last time I was in Jeddah, and I think it was the 7th Saudi Society of Rheumatology. I think the stage was well set before I start my talk. So usually I talk about pregnancy rheumatic disease. I tried my best to add new evidence about lupus and pregnancy. Can I have just the slides here to be shown? Thank you. So I don't have any conflict of interest indirect to this talk, but I do have some honorarium and a grant from different companies for research. So my overview here is that all of us, we knew that lupus pregnancies are high risk, and we knew that preterm birth, preeclampsia, premature rupture of membrane are increased during a pregnancy in lupus population. Pregnancy loss is increased in women with active lupus or with coincidence of antiphospholipid syndrome. Lupus flares can occur in any trimester and are often treated with prednisolone. So this is the general concept. So we will go through them and then we'll see where we are. So what are the triple threats facing any woman lupus who is getting pregnant? So we do have maternal component, which is either a flare of her disease or that she's going to have a preeclampsia or eclampsia. And then we do have a placental component, which is antiphospholipid placental thrombosis, or actually a problem in the homeostasis of the placenta itself if the patient is developing preeclampsia or eclampsia. And then we do have the fetal component, which is congenital heart block and neonatal lupus. So what are the dogma? So the predictors of adverse outcome, we knew that if the patient is in active lupus, or if she does have lupus nephritis or insufficiency, hypertension, and antiphospholipid. So we will go through them. So what are the differentiating disease flare from actual lupus? This is just basic slides. We knew that we can have a rash during pregnancy, which is non-specific like coalasma and other type of rashes, but with lupus, it's a specific different rash, which is usually inflammatory rash. Musculoskeletal is usually an arthralgia with a pregnancy, which is non-specific, but with lupus, it's an arthritis. Hematological, you need to pay an attention to leukopenia and a new drop and a platelet, but not in the third trimester, because we do have a pregnancy-induced thrombocytopenia by itself, and completely it's a different definition. Serologically, rising titer of double-stranded DNA and changing in the complement level, because usually during pregnancy, complement should be either normal or high as physiological changes. Constitutional symptoms, usually patient will have fatigue, and sometimes they can have mild short breath because of the high progesterone level. So what is the impact of lupus on maternal and fetal outcomes following pregnancy? This is a meta-analysis done in around like 350 patients in comparison to 500,000 control. We knew that in lupus population, in comparison to the normal pregnant lady, preeclampsia is increased, premature birth is increased, small for gestation age is increased, stillbirth is increased, and infant require ICU is increased, and all of them with a significant p-value. What about the frequency and the timing of a flare? Is it a mild flare, moderate flare, or severe flare? This is a very old study in 2005 published by Michel Petri, and it was found that in the second trimester it was 12.7 in comparison to 9.6 in the third trimester for mild to moderate, but it is around 2.5 to 3% between second and third trimester for severe. So did we replicate the study? Did we have the same population? Actually, yes. In 2015, we did have the PROMISE study, and it is the cornerstone of any data on a pregnancy, and I advise everybody to go in depth in PROMISE study. So PROMISE study was a predictor of pregnancy outcome in patients with lupus. Resulted from the PROMISE study, they looked at the outcome of lupus patient and antiphospholipid. So we did have 4 different type of patients. So it's either lupus with antiphospholipid, lupus without antiphospholipid, we have a control, so nothing, or lupus by itself. So, and it was defined according to the ACR criteria, and the new in this one regarding the antifossil that it was defined according to the new SEPARO criteria. So beta-2 glycoprotein, IgG, and IgM were involved. It was not only lupus anticoagulant or anticardiolipin antibody. So, and they did have inclusion-exclusion. In this study, they excluded renal insufficiency, they excluded twin pregnancy, and very active diseases. So the outcome was a composite endpoint defined as the occurrence of one or more of the following. Fetal death occurs after 12 weeks and not explained by chromosomal abnormalities, anatomical malformation, or congenital infection, which is a very, very important that whenever you see pregnancy loss in any of your lupus or antifossil, you need to rule out this before you blame your lupus or antiphospholipid. And neonatal death prior to hospital discharge due to complication of a prematurity or a placental insufficiency, or a preterm delivery prior to 35 weeks, secondary to gestational hypertension, preeclampsia, or placental insufficiency. And small for gestational age, less than 5th percentile in the absence of anatomical or chromosomal abnormalities. What about the renal flare? So in this study, we did not have a lot of patients who did have renal insufficiency, just a few of the population, and actually there was only 12 had no adverse outcome because their disease was well controlled, and 5 had an adverse outcome in the form of 1 fetal death, 1 neonatal death, and 1 live birth at 36.5 and small for gestational age. So lesson learned from this study. There are a lot of lessons, and maybe if you go in depth, because I don't have the time to go in depth in this study. So those are my conclusion. In a patient with no risk factor at baseline, adverse pregnancy outcome rate was only 7.8%. Fetal and neonatal mortality was only 3.9%. In a patient who are not white, okay, and have no other baseline risk factor, adverse pregnancy outcome was 11.4%. In patients who are either lupus anticoagulant positive or negative, but non-white and treated with antihypertensive, so the adverse pregnancy outcome was high. So this is telling you that African American, Hispanic, they do have higher risk population of adverse pregnancy outcome. In this study, most of the population were white, around like 70%, and the rest were others. What is the discovery from this study? Lupus anticoagulant is the most powerful predictor of adverse pregnancy outcome. And this is telling us, are we going to change our practice from the guidelines if you find a lady with only lupus anticoagulant with no prior pregnancy losses or any complication? And actually, I did it myself because I do believe strongly that lupus anticoagulant give you the highest pregnancy adverse outcome. Discovery 2, historically, actually, we knew that lupus patients were discouraged from being pregnant, and observational and maternal severe flares in the 2nd and 3rd trimester were very low. So if you control the disease, patient can go into pregnancy like any other pregnant lady in the community. Limitation, they excluded a patient with high disease activity, and their conclusion was lupus patient with a stable, inactive disease can be reassured that severe flare are infrequent, and in the absence of definable risk factors, pregnancy outcomes are favorable. They can identify patients at high risk in the future if they are still recruiting. So what about lupus nephritis and pregnancy? We knew that lupus nephritis, they do have more risk of all the complications to the mother and to the fetus, including preeclampsia, eclampsia, small for gestational age, and intrauterine fetal death. And the thing that can predict this, what I usually do to differentiate sometimes between preeclampsia and lupus nephritis, check your uric acid, the pregnant lady with the uric acid. If you find that the uric acid usually is supposed to be very low during pregnancy, if you start to see it normalizing actually, then you need to think of early preeclampsia. With regard to the medication, so I'm not going to talk about all the medication, but I'm going to stress on hydroxychloroquine, aspirin, and if there is any new data for belimumab, giving that belimumab is an FDA-approved medication for lupus. So regarding hydroxychloroquine, we knew that hydroxychloroquine can protect lupus population. It is safe during pregnancy, it's safe during lactation. It does have a lot of other mechanism than as an immune modulator. It has been studied over a long time that it is decreased risk of a flare. And recently, actually, this paper is just recently published in 2021 that there is low incidence of intrauterine growth restriction in a pregnant patient with systemic lupus erythematosus in patient using hydroxychloroquine. And this is their data that around 32% patient less IUGR than the normal population if they are taking hydroxychloroquine. And longer time of a pregnancy, so they don't deliver early if they are taking hydroxychloroquine, and as we knew that it is safe. What about this study, which is again a new study about hydroxychloroquine in a pregnancy? This is done in one Portuguese center on around 143 patients. The data here is very interesting, that they were, they included actually general type of patient, the one that we do see. So they do have lupus nephritis, 20%. They do have antiphospholipids in their population around 21.9%. During gestation, they have around 80% they were on medication. But the interesting part, how many of those were on hydroxychloroquine? It was only 63%, and this is published in 2021. So since the discovery of hydroxychloroquine in lupus, we are still status quo on the percentage internationally of the pregnant mother who are on hydroxychloroquine, which is around, in all published data, around 60 to 65% maximum. In our own data registry from Qatar, we have around 80%, and I presented that in the previous conferences. What about low-dose aspirin? Was prescribed around 87.9% of the patient, and the live birth rate was 84.2%, and adverse pregnancy outcome occurred in 41.4% of the pregnancies. So again, hydroxychloroquine is a very important medication to prevent a flare, to keep the mother from a longer gestational age, which is very important for later on the growth of the infant. I think I'm going again. It's not moving. Yeah. So again, now I'm going to talk about aspirin, as I said. Why aspirin is important? Aspirin is important because it does give you homeostasis of the placenta. So what does it do? So if you look at this graph, I don't know where's the pointer actually. Okay, so during normal pregnancy, vascular homeostasis is maintained by the physiological level of vascular endothelial growth factor and the transforming growth factor signaling in the vasculature. So your baseline in the placenta is under homeostasis. So what's going to happen in preeclampsia? Excessive placental secretion of the split unit of the vascular endothelial growth factor, because it is attaching to the protein, so it's going to go into the serum. This is going to give you an inequilibrium of the homeostasis, and that's why the risk is going to be for thrombosis and the complication. And actually, the predictive diagnostic tests, those are available commercially. I don't know if you have it in your center, because if you are going to predict preeclampsia in your patient, you can check this in the lab, either the SFLT or the placental growth factor. We don't have it in Qatar, so we don't do it, but in the research centers, it is already commercially available. So what are the data for the aspirin? There are meta-analyses that aspirin improve a pregnancy outcome, and you can see here from 2007 till 2013. So what is the latest data about this? That there was in 2020 in January, Lancet produced a big paper. It's called Aspirin, actually. Low-dose aspirin for prevention of preterm delivery in nulliparous women with singleton pregnancy, and it was a randomized controlled trial. So they showed the safety of aspirin during pregnancy and decreased risk of preeclampsia and eclampsia in normal population. So, and then we knew that from the EULAR and the ACR. EULAR came out with the recommendation 2017, and then ACR came with the recommendation 2020, that we need to give every single lupus patient who are pregnant aspirin throughout pregnancy. So it is safe during pregnancy. So you need to give it throughout pregnancy. It depends on your obstetrician and your anesthetist on delivery. Some hospitals, they advise to stop it at the end of 36 weeks, and this is what I do. I don't do it. I do it for my anesthetist, I don't do it for myself because they are afraid to go with the epidural if the patient was on aspirin. Though internationally, they continue the aspirin throughout the pregnancy. And in other rheumatic disease, do you have a data that use aspirin throughout pregnancy? Actually, we don't have, but some centers, they do advise that. What about belimumab and the pregnancy? We knew that belimumab decreased flare in lupus, either lupus arthritis or lupus nephritis, and it is the FDA-approved medication for lupus. Do we have any data in pregnancy? Unfortunately, we don't have except case report and case series. And this was just recently published in 2021 from one center, actually on 13 pregnancies. On 13 pregnancies, but it was not throughout pregnancy. It was only during the first trimester, and there was no any adverse outcome on the babies. What about belimumab during lactation? The transfer of the belimumab into the milk actually is not high, so you can use it safely during, and this is a courtesy from the ACR last year, this is slide. And there is no harm if you breastfeed during, but still we need more data because now there is a belimumab pregnancy registry ongoing worldwide. I'm going to go quickly through antiphospholipid because I cannot leave antiphospholipid during pregnancy, and I'm talking about lupus. So we knew that there are risks of embryonic death, growth restriction, and preeclampsia. Again, this is from the PROMISE study that the most adverse pregnancy outcome comes with patients with lupus anticoagulant. And the new things in antiphospholipids that you can use TNF to prevent pregnancy losses during pregnancy. And this is a courtesy of Jane Salmon's slide. There is already 11 patients enrolled, and the outcome was an excellent in refractory pregnancy losses. So we are still waiting for the full data to come out. What about neonatal lupus? Because a lot of lupus patients or other connective tissue disease, they do have Rho and La antibody. And we knew that there is a problem either with congenital heart block or with a neonatal rash. So the dependent factor are the antibodies, independent is maternal health here. I'm not going to go into details because the moderator is telling me I don't have time. Again, I just want to show you that the importance of hydroxychloroquine for any mother who is Rho and La positive, because significantly there is a drop in the incidence of congenital heart block. We replicated this study, and inshallah soon we are going to publish our paper that if the mother is taking hydroxychloroquine, the risk of congenital heart block is way, way, way lower than if the mother is not on hydroxychloroquine. Those are just the safety of medication during a pregnancy from the American College of Rheumatology guidelines that has been published in 2020. And in conclusion, rheumatic diseases should ideally be well controlled for several months in advance of a pregnancy. Patient taking medication that are potentially not compatible, given that we do give actually cyclophosphamide, we give rituximab, we give Cellcept, we give a lot of other medication for our lupus, so we need to control them before the pregnancy and then switch them to a compatible, safe medication during a pregnancy if they need it. Check antibodies in every single pregnant woman coming to your clinic, even if she's rheumatoid, because most of them, they will have Rho and La and they are asymptomatic. And we've been seeing a lot of retrospective congenital heart block in some of the population. And at the end, I would like to acknowledge actually my team because we do have a pregnancy registry. We have more than 1,500 pregnant in this registry, so I welcome anybody for collaboration in research in pregnancy and rheumatic disease. I would like to thank Dr. Iman Sati, consultant rheumatologist, Dr. Nawal, she's also a consultant rheumatologist, and my, actually I can say hero, research coordinator because she's filling all the data, Ms. Hadi Al Ashur. And thank you very much.